Hello, I'd like to speak to you for the next 10 minutes on chest x-rays. I hope that this is going to be helpful and will enhance your knowledge and not confuse. Let me know if you have any questions. First of all, just a little bit of revision of anatomy. What we have here is a diagram of the respiratory tract, both the upper respiratory tract and the lower respiratory tract. The point where it changes is the vocal cords, which are inside of the larynx or voice box. So everything above the vocal cords is the upper respiratory tract, and everything below is the lower respiratory tract. The diagram also goes through all the names of particular, the trachea, which is your main windpipe, and it bifurcates or splits into two at a place called the carina. These places are something I'll come back to later on when we're looking at the x-rays. Also surrounding the lungs is what's called the pleura. This is a very thin membrane which goes all the way around the outside of both lungs, and it is a barrier which separates out the inside of the chest wall from the outside of the lung. And between the two layers of pleura in this space here is something called surfactant, which helps keep the outside of the lung stuck to the inside of the chest. And then when the chest wall moves up and down, the whole lung moves with it. This becomes important when you think about stuff which can actually get into this little space here. And we'll come back to that again later in the chest x-rays. This is a normal adult x-ray. I wanted just to talk briefly about the features which you can find on the x-ray. First of all, looking at the pink outline there, this is the heart, which is usually left-sided and is normally less than 50% width of the whole chest. The area above the heart, which I'll just highlight here, is called the mediastinum. And in adults, it's normally very narrow. A feature which might hopefully help you focus your eyes is to count the ribs. If you just look at this one here, this is what's called an anterior rib, and you can follow that number 1, and then this number 2, number 3, number 4, 5, 6, 7, 8. And the posterior ribs, one here, one there, one there, one there, one there. Try and focus your eyes into looking at the anterior side and the posterior side. Counting these ribs can help you to work out sometimes if there's something wrong with the child that you've just x-rayed. In purple and pink here we have the diaphragm, which is normally got a right side that's higher than the left side. This is because down here we've got a very large organ called the liver. On the left side below the diaphragm, it's normal to see air and a stomach bubble. This is where your stomach is. On the right, there should never be any air underneath there. The midpoint of the diaphragm should bisect the 6th anterior rib. Looking at this area here, where the heart angle joins in with the diaphragm, and here these are called the cardiophrenic angles. Cardio meaning heart, phrenic meaning diaphragm. The angle where they meet is the cardiophrenic angle, and the costophrenic angle. Ribs being costo, and phrenic being the diaphragm, the costophrenic angle. These are areas which sometimes you can lose the sight of in things like infection. And highlighting here in pink is the trachea, the main windpipe, and the carina, the point where it turns into two bronchi. It should be central, right in the middle, and beyond the bronchi, the rest of the lung isn't visible. You can't see things like the bronchioles, the slightly large tubes, and the alveoli, the smallest part of the lungs, which come all the way around to the outsides of the lungs. Those are invisible to sight, and in normal chest x-rays. The pleura, again, goes all the way around the outside of the lungs. You can't see it. If you can see it, then there's something abnormal. This is a brief diagram which shows this normal anatomy that you can find on a chest x-ray. You can pause and look at that if you like. Flipping straight onto a paediatric x-ray, it suddenly becomes very obvious that it's different. Some important features on this x-ray would be stuff like the massive heart. There's fluid. You see this little white dots all through the lung spaces on either side, and the bone spaces are really far apart in comparison to the adult x-rays. The ribs are actually very bendy and are sometimes odd looking positions. you can see just right here a line of fluid. That's fluid in the fissure. That's because this is a brand newborn baby, which means that they've still got some fluid in their lungs from when they were inside of mum's womb. This is something which we call transient tachypnea of the newborn. Another pediatric x-ray of a child that's now slightly older, you're starting to see some growth plates in the bones here, and the distance between the joint is far smaller than before. But still, we've got similar signs that the heart is very large. The ribs are more formed, and the mediastinum, the area above the chest, is quite wide there in comparison to the adult x-ray. There's not much in an adult x-ray in this area, but with kids you can see that's quite a wide gap there of something behind the sternum. That is a thing called the thymus, which disappears in adults. Again, a slightly older child again, probably a teenager now to be honest. We've got fully formed joint spaces in the corner, and I'd like just to talk about how I would assess an x-ray. And this process should work for any patient. I usually follow an ABCDE approach. It's very helpful in general in medicine. I start off with A, so is the trachea straight? Can you see this area here? You see that dark area of nice straight drain pipe darkness? This is the middle of the airway, and it should be straight down the middle. B for breathing. Are the lung fields clear? Looking on either side of the lung, is it clear? Have you got some kind of area that's full of white dots, or even solid white in total, or does it look symmetrical on both sides? You can see some normal wiry kind of hazy opacifications on both sides. This is perfectly normal and present on all x-rays. But is it more than that, is the question you're asking yourself. C for cardiac. Is the heart a normal size, shape, position? Does it look odd to you? D, is the diaphragm normal? Is the right side above the left? Or is it far above than you'd expect? It should, remember, bisect the 6th anterior rib. And is there any air below the diaphragm? And E for everything else. Make sure you pay close attention to things like the bones and the soft tissues outside of the lung fields, and the air that you can see underneath. So sometimes you can catch something else outside of the chest on a chest x-ray. Common things which are missed on chest x-rays are things like pneumothoraxes. We'll show you an example later, but you look all the way around the pleural space to make sure you can't see any black areas, to make sure there's no pneumothorax. So we've got our x-ray here, and obviously you follow your A to E approach, you'll notice the airway straight, the breath fields are nice and normal, the heart is in a good size, the diaphragm looks perfect healthy, and everything else you notice, hey, there's a tube here, and this tube seems to go straight down the middle and then turn left as it goes underneath the diaphragm. This is of course an NG tube. And sometimes you might do an x-ray to confirm the position of an NG tube. What you want to always check is that NG tube going straight down the midline? Does it bisect the carina? Does it then go below the diaphragm a good distance, and then you can be confident that the tip of the NG tube is in the stomach. Obviously use other techniques such as aspirating and checking the pH too. This x-ray, again, airway is nice and straight. Breath fields look asymmetrical. There's something different here, isn't there? Again, follow through the rest of the process. The cardiac size looks normal in a good position. Your cardiophrenic angle looks normal there, but it's just slightly lost in this area. You're starting to notice that there's too much whiteness in there. It's not quite as clear as the one on the other side. This is a right-sided lower zone pneumonia. Obviously, you don't always have to do a chest x-ray to diagnose pneumonia, so history and examination sometimes is even more important, and things like fever, hypoxia and tachypnea in a child can point you towards a diagnosis of pneumonia. You might also find crackles on this right side of the chest when you listen with a stethoscope. Here we have another x-ray. Airway looks like actually it's slightly over to the left. This airway doesn't appear to be going straight down the middle as we've seen in other x-rays. It's quite hard to spot really. Anyway, then you go to B and you've got a great big asymmetry here, haven't you? This left side may look like normal kind of lung spots, but on the right side you've got a big black gap in there, haven't you, between the ribs? You can see quite clearly that that space there is black and this space in here is not fully black. You have in this area a pneumothorax, a right-sided lung pneumothorax, and that needs to have a drain inserted. Here's an example of a different child, but with a chest drain inserted, where we push a small pigtail tube inside the chest through the outside and drain the air. When is it a tension pneumothorax? If this air that's stuck in this space here is rapidly getting bigger, then the lung will be pulled in, this will be pushed in towards this space, which will then start to impede on the heart and its function. That's a medical emergency and gets called a tension pneumothorax. So what you need to do is grab a cannula and insert it directly in here in the midclavicular line in the second intercostal space. That should cause a rush of air and cure the patient miraculously. It's one of those movie star kind of moments that doesn't actually happen very often in hospitals, but a tension pneumothorax is something which people. And finally, just to highlight an important point, that this x-ray shows a child has ingested a foreign object. You can see obviously here and here in the side view that there's a foreign object stuck in this child's upper esophagus. This looks like a coin-shaped item. It's circular, but there's a thin rim. You can see quite clearly that goes around it. And the side view, it doesn't look quite like a coin. It looks like there's a bit of an angle towards the front end of that item. This is a button battery, and if ingested, it can be fatal to young children, unfortunately. A button battery is easily short-circuited and becomes very hot if left in a mucosal environment like your esophagus, and it can actually burn directly through and cause significant internal trauma and even death. Button batteries are the evil, and everyone in paediatrics needs to be aware of how dangerous it is if there's any suspicion a child has ingested a button battery.